Hello?
Yes, sir.
Yeah, the slides are visible?
Yes, sir. In the panel,
Okay. Yeah, go ahead, please.
sir. Yes, sir. In the panel discussion, we are having Dr. Tarachand Gupta, who is a medical oncologist from Jaipur, Dr. Vibhor Sharma, who is a medical oncologist from Delhi, and Dr. Nitin Chaudhary, who is from medical oncologist at Jalgaon, and Dr. Siddharth Turkar, who is present in person in Mumbai. And
So, good morning, everyone, and it's nice to have this different hybrid kind of a meeting. We have started having physical meetings, at least within our city, but I think it's a little bit time, Omicron permitting, that we start actually having more physical meetings. Right. So, I am going to be talking about the ALK side story, as I would call it, where you have the plucky old crizotinib, which we have all used, versus a new and more flashy kind of drugs that have come in. And let's see how we are going to go about this. And I'll focus mainly on the abstracts that have been presented till now. And we'll see where to start placing it. That's the theme. Let us start off with one case which will give us an idea of what we are dealing with. So a 50-year-old gentleman, ex-smoker, presenting with only coughs, no fever, no hemoptysis. He was evaluated for COVID, and then he was found to have a lung nodule, multiple mediastinal nodes, underwent the EBUS biopsy. This is the mediastinal nodes, as you can see. And from here, aspirate as well as biopsy was taken. And from that, the report was given as a adenocarcinoma. So we went ahead and did a PET scan as is usual, and it found multiple bone mets, as well as lung metastasis, and as well as the mediastinal nodes. Okay, so this is the PET scan report. As you can see in the PET scan, the brain is normal, and you have a 2.5 centimeter mass, not too large lymph nodes, and again, some bone metastasis were also seen. Right. So this patient was then tested with an ALK testing on IHC, and it turned to be positive. PDL1 was 0%, EGFR, ROS1, and BRAF would be negative. So let me just start off straight with Dr. Tarachan. Your photo is on the top of my list, so you're the first person who gets the call. Are we okay with doing FISH alone, or are we doing NGS on a routine basis now for
ALK? Thank you, Dr. Vamshi. And actually, we are preferring NGS if the patient is affording for the other drugs also. If patient is not affording for the immunotherapy or other higher molecules, then we are not offering NGS, because I don't think there is any much benefit of doing the extensive panel if patient is not affording. And if the patient, or if then we are doing EGFR ALK ROS, which is being on complementary coupons also, so that we can go with mostly affording drugs.
Sure. So, Dr. Vibhor, I mean, let's, for the purpose of the next 20 minutes, kind of remove ourselves from routine practice where we talk money for everybody. Let's assume that, we have a choice of treating everybody as the way it is. I understand the value of money, but, it's becomes a little difficult with each case if we start talking each sentence that each patient can afford. So, Dr. Vibhor, your thoughts on this? Would you do an NGS for everybody, or would you be okay with just doing IHC and then doing EGFR differently and stuff like that?
Sir, I broadly agree with what Tarachand has said. Not much difference in my approach also.
Okay. Very good. So this patient came as ALK positive. So now let's just look at the abstracts that were presented. So we had 3 abstracts which were actually very similar. So you have ensartinib versus crizotinib, a phase 2 trial for patients with ALK positive NSCLC. You had the final analysis of the JLX trial. Remember, this is the JLX, not the ALEX study. And then you had the CROWN study, the initial presentation, right? These were the 3 things that were presented to us. So let me just put up here what the patients were, including. The JLX was ALK positive, all Japanese, 1 chemo could be allowed. Ensartinib, ALK positive, ALK inhibitor treatment naive, but 1 chemotherapy allowed, 290 patients. CROWN, again, similar amount, 296 patients allowed. So, Dr. Nitin, just looking at the patient pool, do you think all trials are actually enrolling almost the same patients? So, just based on the trial inclusion criteria, do you think we should differentiate between different drugs, or all of them fit all the drugs? Dr. Nitin, are you there? Is he on mute or something? I can't see his. Okay. Dr. Siddharth, you're there in the audience?
Yes, sir.
Yeah. So what's your thoughts on this? Just looking at the initial, the patient pool in all the trials, is there anything to say that we'll be allowed to differentiate patients from drugs just on the basis of trials? So look at the way the CNS meds are allowed in every case. The primary endpoint has been only PFS for all the trials. So how do you differentiate the drugs based on the trial inclusion criteria?
So, no, based on trial inclusion criteria, there is no differentiation. But with
Right.
crizotinib, if brain metastasis is there, then I will not prefer that drug.
Okay, we'll come to that. What do you prefer in each case? We'll come to that. So, Dr. Tarachan, your thoughts on the different populations in ALK. Do we really start looking at what kind of an ALK mutation it is? Are we looking at the, yeah.
Yeah, I think if I go these three trials according to your slide, then the uncertainty is also not good for the brain mets because they allowed only the asymptomatic metastatic sites, not a high burden disease.
Okay, I have not
And
written
this,
this.
that was a phase, and
Okay,
that
my
was a
mistake,
phase two trial.
Okay, my mistake.
That
All
was
of
a
them
phase
did-
2 trial also. That
Okay,
was a phase 2 trial also. And for another differentiating point, for otherwise for the brain mets, I can go with the lorlatinib and alectinib, either option. But till date now the PFS OS is available only with the alectinib, not the PFS, not the with lorlatinib. So if I have to choose among these two, then I will go with the alectinib first. However, there is a data in the Asian study, that is Japanese study, that is not showing any OS benefit with the alectinib, but still there is a broad data, and so I have another choice that alectinib should be superior than lorlatinib in my till date till the OS data is available with the lorlatinib.
Okay, so you have jumped 3 slides ahead of what I was going to ask you, but that's fine. That's all right. That's fine. So what I was asking was, since all the 3 trials look similarly, and again, it is my mistake, all of them allow asymptomatic meds, or treated or asymptomatic, which has been treated, presently asymptomatic. So the trials are actually similar in that. I'm actually more curious about the endpoint that was the primary endpoint. Dr. Vibhor, is PFS the right endpoint for ALK trials?
Actually, I think these are all stage 4 disease. So, quality of life and OS, these are the 2 most important things. But yes, PFS, all these studies have shown an improvement over the first line crizotinib.
Correct.
If we compare cross drug comparisons, what strikes is that after the second line agents, we still have the option of lorlatinib, but in that Crown study, after lorlatinib, we don't have option of hardly anything other than to go ahead with chemotherapy. So OS would be a more validated endpoint, I feel, as compared to PFS. And if we look at the again, making the cross trial comparison, but if we look at any of the second line agents compared to crizotinib, it's between 24, 25, 26 months with the second line agents, and crizotinib is somewhere at around 10, 11, 12 months. It is almost same. So what we have to choose between is the side effect profile, the presence of brain metastasis. One factor which is very important is the availability of lorlatinib upon progression on second line agents.
Okay, very good. Dr. Nitin, have you joined back? I think Dr. Nitin is not there. Very good. Siddharth, if I can ask you the same thing.
Yes, sir. If PF, although OS is a better endpoint, but still, as ALK positive NSCLC, the survival and the response with each agent is very high. So first of all, it will be difficult to get the data till OS, and so we have to settle sometimes for the PFS. Second thing that I want to say is most of the patients progress in a way with brain metastasis, and sometimes we are not able to give the second line drug. So that's why it is better we treat with the best possible drug if finances is not an issue. So PFS, that's why I feel, is a acceptable endpoint.
Okay, I just lost Dr. Siddharth last point, but yeah.
If you what I said, if because most of the patient progress with brain mets, and sometimes we are not able to give the second line also. So that's why it is better we use the first drug, the best possible first drug if possible. Yeah.
Okay, fine. So let's go with the trial, and I'll see we'll also examine what the data very interesting data which actually came up from the JLX and regarding this point of progression and whether we can use the second line or not. Now these are the results. Now the Crown study that has not reported it, though it gives you a hazard ratio of 0.28 for the PFS, hazard ratio 0.51 for ensartinib, hazard ratio for JLX is 0.37. The hazard ratio in the LX was somewhere around the same. The hazard ratio in the Ascent gives you around 0.6, 0.5 to 0.6. So the PFS everywhere is very good. OS, look at this, the Crown is immature, ensartinib immature. The one place where you do have it in the JLX, it is 1.03. In the LX again, it was significant, but it's 1.03 here. So Dr. Tarachan, OS is not significant in a big trial. Remember, the JLX was something which was touted as a game-changing thing, and then the LX was game-changing. When you're not getting an overall survival advantage, what's the benefit of giving these drugs in the first line? Why not good old crizotinib?
Then I think if there is no OS benefit, then we can focus on the PFS benefit if the finances are not better, because PFS always gives a quality of life better. Then if the PFS is good, then the quality of life will be always better.
Dr. Vibhu, do you agree, since PFS is better, quality of life? Again, someone made the point that, second line they may not be able to get, so pack your maximum punch in the first go itself, give the maximum PFS. That should be the way to go ahead. Is that, do you agree with that?
Sir, in my clinical practice, I usually offer second line agents. One more thing I would like to point out here, since any of the agents that we offer, patient has to take for a prolonged period of time, 2 years, 3 years, like that. So as we see in CML also, nilotinib, whichever drug is to be taken on a BD basis on a daily note, the compliance also becomes an issue in the real world setting. So I think an OD.
This is progress. If we are comparing NSCLC to CML, I think that is the real progress for all oncologists. If we actually start comparing the two. But yeah, I take your point. It is something that we need to discuss with the patient, whether taking 2 tablets versus 1. I'm not sure how much alectinib, if you take multiple tablets in a day, is easier, or the lorlatinib, you need to take 4 or 5 tablets a day, is easier in any way. But I take your point. We need to discuss with the patient how you're going to give the drugs. Now, I just did the last follow-up. Intracranial response rate. We keep talking of the brain metastasis. I have not put the JLX here. Even there, the brain results are better. Everywhere, if you see the intracranial response rate in the Crown, in the ensartinib, everywhere the intracranial responses are fantastic. In fact, the Crown, they had a 71% CR rates. So, for patients with brain mets, is this more important? Do we need to look at the second and third generation for the brain met group at least? Dr. Siddharth, what's your thought?
Yes, sir. I think that it is a good endpoint, because many patients are presents with brain metastasis, and most of them progress with brain metastasis. So having a response in brain do really matter, because it is going to affect the quality of life.
Okay, so that in patients with brain metastasis, you would definitely not think of crizotinib alone, if I understand you correctly.
Yes.
Intracranial responses, there are 23% and 25%. Yeah. Okay. Very good. So again, this is an interesting thing when you look at the other part of it. The toxicity is something we do not consider. Now, the interesting thing is in the Crown, in the ensartinib, both the places, the grade 3, 4 are actually more significant than crizotinib. The discontinuation rates were similar in both the studies, though the numbers are not too much. The subsequent therapy was not reported for others except JLX. So looking at this, do you think it is still a doable thing, or it is something we should not be doing? Dr. Tarachan.
If the toxicity concern is again, I see your slide, then it looks in Crown there is a higher toxicity, but that toxicity was hyperlipidemia. I think it was a well managed toxicity. That is not of a great concern, I think, because I don't think that in nowadays lung cancer patients are surviving in stage 4 for more than 5 years at present. There any OS or say 5 years, 6 years. So I think hyperlipidemia, if can be controlled in a very well manner, then it's a good drug, because it was a grade 3 with hyperlipidemia only. Other toxicities were
your personal experience with alectinib? What is your personal experience with
alectinib? Sir,
serotonin is now, I use that. We're not talking about it.
No, alectinib I used in only my training time, and that's why after that I could not follow those patients. But yes, I am using lorlatinib nowadays, and the patient are tolerating well without much side effects.
Dr. Vibhor, your thoughts on the toxicity wise, Crizo versus these drugs are hugely different or all are
One
manageable?
unique toxicity of lorlatinib, as they have reported in the trial, is the cognitive decline and mood
Mood
changes.
disturbance. Yeah.
So important for elderly patients in this point. And
Personal experience, have you seen anybody having this issue? I have a handful of patients on Lorla. So far, all are pretty much okay. But then, for your personal experience?
No, my personal experience, I have not seen that. And if we look at the trial data, I think they have reported that grade 3, grade 4 toxicities with alectinib are lower than that of crizotinib. And even the in both the
Yes,
Alex as
yes,
well as the JLX trials, that is something
correct.
notable.
Correct. So, Dr. Siddharth, your thoughts, toxicity wise, are these drugs really going to be that difficult, or are they really going to help you differentiate between the different drugs, or
Yes,
they're
sir.
all manageable?
One thing that Dr. Vibhor has told, that alectinib has actually better safety profile and it has lesser interaction with other drugs. Because in my experience, I have used alectinib in two of my patients. One patient was already on AKT, which have too many drug interactions. The automatic choice for most of the time for us is seritinib because of the cost, because it is even less cheaper than the crizotinib, but it has too many interactions. So in those cases, seritinib really helps. I have two of my patients who are having multiple comorbidities. So that also affects the decision.
This was for me a very eye-opening study. JLX showed that patients who were on crizotinib discontinued much earlier, but lived slightly longer post discontinuation. And they actually showed you that slide where you had a nice curve of the crizotinib going much further up, because those patients took alectinib as a crossover. Almost 80 to 90% patients actually took a second line drug. So in a situation, I mean, let's assume that your patient is billing and is fit to take alectinib in the second line or lorlatinib in the second line. Is alectinib still better to be used in the second line? Should you use it in the first line? Dr. Tarachan. Okay, he's busy. Dr. Vibhor.
Repeat your
My question was, when you look at the JX, patients who were able in crizotinib arm to take alectinib in the second real life. Patients on first will go on to a second line. So do you think alectinib should be reserved for a second line, or should you use it as a first line? Because that's what the JLX seems to tell you.
Yes, I think alectinib should be used in the first line, not in the second line, because in real world practice, once the patients progress, hardly I think 50-60% will go on to ever receive the second line. So if and plus the brain metastasis part also, if somebody is having brain mets, there too alectinib will work better than this, than crizotinib. In terms of side effect profile also, it is better. So why he should not be given alectinib as first line as compared to crizotinib.
Okay. Dr. Hassan, agree with this? Do you think the alectinib is still okay as a first line? Because remember, there's no OS benefit. You're fine with that because second line they won't effort. I mean, they won't be able to take a lot of patients. That's what the panel seems to be.
Yes, already we just discussed that if the OS is not the criteria, then we will go with the PFS. But if you ask me that what is the practice, then yes, I agree with the Siddharth that I am using the seritinib and then followed by in second line the lorlatinib or the alectinib I am using at present. But yes, if you ask theoretically, then it is PFS will be the criteria for me.
Yeah, dear moderator.
theoretically,
Last 1 minute to last 1 minute.
1 minute only. It's only been 20 minutes. Okay, I thought I had 30. No problem. We'll finish in 2 minutes. Fair enough. So this data. Now this is the second line. Now, Dr. Siddharth, you said that seritinib is something we will be using more often because it is easier and cheaper slightly. This was the real world data. Second line. Do you think we should really trust this? Because remember, the real world have a cross trial comparison based on some trials. So, Dr. Siddharth, your take on this study?
Because for seritinib, but asking me.
So this study, which we have just presented, which was presented before us, was in second line alectinib versus seritinib. right? That was the study that was presented to us. So I'm just commenting on that paper, that according to that paper, probably elective is slightly better, but are we even using crizotinib in the first line? Does it matter? And if yes, then what would be your second line, serotinib or elective?
So for the second line, for me, in most of my patients are serotinib, but I will prefer alectinib for the same reason Dr. Vibhor has already told, that if patient is affordable, then I will go for alectinib. It is a better drug, better molecule.
Dr. Tarzan, first line goes to crizo, supposing, then second line electinib versus serotinib. Are you comfortable with this real world data and then say that electinib is better?
Electronic should be better, I think.
Electinib is better. Fair enough. Okay, so most important question, all of us have spoken about this thing. So most important thing, Dr. Vibhor, forget crizotinib as the first line, or do you still feel crizotinib has a place as first line?
No, we don't forget crizotinib, sir.
So after discussing and saying that
Strong
electinib
emotion
what we
attached
all
to
give, but we then
crizotinib,
say
sir.
we'll go back to crizotinib. Yeah, it's like comfort food. At the end of the day, you want your comfort food of crizotinib. You don't, even though the new thing looks very interesting. So more important, Dr. Vibhor, all patients you would suggest the same, or would you reserve it for those patients without CNS metastasis? And would you consider that CNS metastasis is something where you would like to use the newer ones?
No, definitely CNS metastasis is something which I would like to use the newer ones.
Okay.
No doubt in that.
Dr. Tarzan, your thoughts?
Yeah, I agree with Dr. Vibhor that in brain metastatic patient, I will be use new molecules.
New molecules. Okay. Dr. Siddharth, I'll put you on the spot. Patient with brain mets, lorlatinib versus electinib, what would be your choice?
Alectinib.
Electinib will be your choice, followed by lorlatinib. Very good. So despite the crown getting a positive result, we are still, I think, a bit wary of jumping the gun and giving lorlatinib in the first line. Remember, lorlatinib in the first line is giving you a good PFS. We really don't know how many months. It's a positive study. We know it's giving you long, but then probably we are still a bit hesitant because we don't know what we're going to do next. So this was the discussion about the various inhibitors and how do you decide. I think our panel has done a more balanced view of what we do in real life. All of us would want to probably give the second and third line, but in practice, many of us are still comfortable giving crizotinib. I have to say, after the JLX and the lack of OS, I'm not a huge fan of now jumping the gun for everyone. This was the last study and final word. Dr. Taranjan would like to take this. Do you think we are going to start looking at ctDNA? Is it going to replace our imaging, or are we still a bit away from this?
No, I will still wait for, because till it is easily available in everywhere, or you can say at every oncology center, so that the report can be procured within times, and till the perfect guidelines comes, then what is the criteria for the circulating tumor DNA progression also, that is not a very good cutoff at present.
Very good. For me, the most important thing is whether we'll be able to start looking at evolving mutations and resistance mutations, and whether we should change based on that rather than just the image. So that's what I am looking for, but I agree it is not yet probably ready for prime time. So thank you everyone, and thanks for a lovely discussion, though I did have to cut 5 minutes of the discussion probably. Thank you everyone.
Thank you, Vamshi. And thanks for the stable internet connection this time.
It's in the hospital, so I'm always stable here.
Thank you.